to everyone. A very warm welcome to all the participants joining us today. Today, our session focuses on an important and highly relevant topic in critical care practice, which is the title of Energy and Protein Delivery in Critically Ill Patients. It is my great honor to introduce our speaker for today. Dr. Zheng Yii is a senior lecturer in the Department of Anesthesiology, Faculty of Medicine, University Malaya. He is also a visiting scientist in Charité Berlin and University Hospital Warburg, Germany. He has more than 50 publications in World of Science cited journals, including the Lancet Journal. He is one of the editorial board members for the Journal of Parenteral and Enteral Nutrition. He is also the lead coordinator for the Critical Care Nutrition Systematic Review, which serves as an important resource for critical care nutrition practice guideline. Since 2019, he has obtained more than 1.9 million ringgit of international grant for his research in critical care nutrition. Without further ado, I would like to invite Dr. Lee to begin his presentation. Over to you, Dr. Lee.
Okay, good morning, everyone. Thank you very much to Dr. Ka Ting for the very kind introduction. So let me try to share my screen first. Okay, so again, good morning, everyone. I would like to first thanks to the Faculty of Medicine as well as my department for the opportunity to present on a topic that is very close to my heart, energy and protein delivery in critically ill patients. So this presentation will review the current evidence on energy and protein delivery on outcomes in critically ill patients. So for energy, we will start with current guidelines recommendation. Then we will review 4 landmark trials with a summary. Similarly, for protein, we will review current guidelines recommendation and then review another 4 landmark trials with a summary. And at the end, I will suggest an overall recommendations for clinical practice based on the current evidence. So the guidelines that we most commonly refer to are the ASPEN, the American guidelines, and the ISPEN, the European guidelines. So here I also include the latest guideline from the French group, which was just published in year 2025. So for energy, ASPEN suggests 12 to 25 kilocalories per kilogram in the first 7 to 10 days of ICU stay. While the ISPEN suggests that if indirect calorimetry is used, we provide isocaloric nutrition progressively after the early phase of critical illness, that is day 3. And after day 3, then we increase to 80 to 100% of measured energy expenditure. But if predictive equations are used, then we need to provide hypocaloric nutrition that is below 70% of estimated needs in the first week of ICU stay. While the French guideline recommended 6 to 8 kilocalories per kilogram in the first week of ICU stay in mechanically ventilated patients, and then increased to 20 to 30 kilocalories per kilogram at the end of the first ICU week. So which recommendation that we need to follow? So let's review the results of the 4 landmark trials regarding energy delivery. So the first trial is the Eden trial, published in JAMA in year 2012. So the Eden trial randomized 1,000 patients within 48 hours of acute lung injury onset and within 72 hours of intubation. They randomized the patient to either trophic or full feeding for up to 6 days of intubation. So the intervention started around within 72 hours of intubation, and the actual energy delivery were around 400 versus 1,300 kilocalories per day. The study primary outcome, 28-day ventilator-free days, were not different between the 2 groups, while other clinical outcomes such as 60-day mortality, ICU-free days, and ventilator-associated pneumonia were also similar between the 2 groups. But compared to the trophic group, full feeding group experienced more days with regurgitation, vomiting, elevated gastric residual volume, and constipation. The full feeding group also had higher blood glucose level and insulin administration in the study period. So the investigators continued to follow up this patient for up to 1 year and found that the quality of life and physical function outcomes were not different between the trophic or the full feeding group. Next is the PERMIT trial, published in New England Journal of Medicine by Professor Yassin Arabi from Saudi Arabia. So the PERMIT trial randomized 894 adults that can be fed enterally within 48 hours of ICU admission and not required a very high dose of vasopressor. So they randomized the patients to permissive underfeeding versus standard feeding for up to 14 days in the ICU. So the permissive underfeeding group target 40 to 60% of calorie requirement, while the standard feeding group uh, uh, target 70 to 100% of calorie requirement. So the intervention started within 8 hours of ICU admission, and the duration of intervention was about 9.4 days. The actual nutrition delivery was about 71% versus 46% of the estimated calorie requirement, that is around 16 versus 10.6 kilocalories per kilogram per day. And the primary outcome was 60-day mortality, and this primary outcome was not significantly different between the two groups. While secondary clinical or gastrointestinal tolerance outcome were also not different between the groups. However, they found that the incidence of renal replacement therapy was significantly higher in the full compared with the permissive underfeeding group. And their subgroup analysis did not find any interaction in all the predefined subgroup. The third trial is the target trial by the Australian and New Zealand group. It was also published in the New England Journal of Medicine. So it is a double-blind randomized controlled trial that randomized almost 4,000 mechanically ventilated adult to energy-dense versus routine enteral nutrition for up to 28 days in the ICU. So the energy-dense group received enteral formula with calorie density of 1.5 kilocal per meal, while the routine group received standard enteral formula with calorie density of 1.0 kilocal per meal. Both formula had similar protein density. So the intervention started within 16 hours of ICU admission and continued for around 6 days in the ICU. And the actual nutrition delivery was about 30.2 versus 21.9 kilocalories per kilogram ideal body weight, with similar protein delivery between the two groups. So the primary outcome, 90-day mortality, was not different between the two groups, and secondary clinical outcomes, including 28-day ICU or hospital-free days, renal replacement therapy incidence, blood culture, and 180-day mortality were also not different between the two groups. But compared to the routine and enteral group, the energy-dense group had more episodes of regurgitation or vomiting, needed more prokinetic therapy, and had higher blood glucose level. And at day 180, among the survivors, quality of life or employment outcomes were not different between the two groups. And last is the Nutria 3 trials. So this trial randomized 3,000 mechanically ventilated adult patients who received vasopressor for shock within 24 hours of intubation to low versus standard nutrition dose for up to 7 days in the ICU. The low was defined as 6 kilocalories per kilogram and with 0.2 to 0.4 gram per kilogram protein, while the standard group, the target was 25 kilocalories per kilogram and the protein was 1 to 1.3 gram per kilogram protein. And the reason why it is called standard is because it is according to the European guideline recommendation. So the intervention started around 17 hours of intubation and continued for up to 7 days. And the trial actually enrolled a group of very sick patients with baseline NORAD equivalent dose of 0.5 mg per kilogram per minute. And during the intervention period, the actual energy delivery was about 7.4 versus 22.0 kilocalories per kilogram, and protein was about 0.2 versus 0.9. And during the intervention period also, the standard group had more vomiting, needed more prokinetic therapy, there were more diarrhea incidents, and their lactate level and liver enzyme levels were significantly higher, and there were more incidents of hypophosphatemia and higher glucose level and insulin delivery in the standard compared to the low feeding group. And this trial predefined two primary outcomes. 90-day mortality is the first primary outcome, which was not different between the two groups, but time to readiness for ICU discharge was longer in the standard compared to the low group. For the secondary outcome, the standard feeding group compared to low group had a trend towards higher ICU mortality and infection, and they needed more time to wean from mechanical ventilation. and they also had more incidents of vomiting, diarrhea, bowel ischemia, and liver dysfunction. So in summary, four large trials investigated different level of energy doses, uh, uh, comparing between trophic versus moderate for the Eden trial, or trophic versus full feeding for the Nutria 3 trial. And for permit trial is around low to high moderate, and while for the target energy trial is low versus high full feeding energy doses. So most trials started the intervention very early, within 1 day of ICU admission, and continued this intervention for about 1 week in the ICU. And the trials investigated mostly mechanically ventilated patients from a lower level to higher levels of disease severity. And what was found in the trial was that none of the trials found any positive outcomes with the higher energy group. On the contrary, all trials found that the higher energy group had worse GI tolerance, metabolic, or clinical outcomes. And it seems that the sicker the patient, early high dose energy delivery will worsen organ function and can increase short term mortality. This is especially evident in the Nutria 3 trial, whereby they enroll a group of very, very sick patients. So early high dose energy is not beneficial and can be harmful. How about protein? Well, higher protein delivery accelerate patient recovery. So now let's review the current guideline recommendation again, this time for protein. So the Aspen American guideline recommended a wide range of 1.2 to 2.0 gram per kilogram of protein, while the European guideline recommended 1.3 gram per kilogram and increased to this target progressively, while the latest French guideline recommended 0.2 to 0.9 gram per kilogram in the first ICU week in mechanically ventilated patients, and increased to 1.0 to 1.3 gram per kilogram at the end of first ICU week. So again, which one to follow? So now let's review another four large protein trial. So the first ever large trial about protein doses is the EFFORT protein trial, led by Professor Darren Halen from Canada. So EFFORT protein randomized 1,300 mechanically ventilated adults with high nutrition risk from 85 ICUs in 15 countries. This was published in the Lancet. So our ICU is actually also part of this trial, and we actually enroll the second most patient by center. So within 96 hours of ICU admission, the patients were randomized to high versus usual protein target. So high target in this trial means at least 2.2 gram per kilogram, and the usual protein target in this trial means not more than 1.2 gram per kilogram protein target. And this continued for up to 28 days in the ICU. So the intervention started around 39 hours from ICU admission, and the average duration of intervention was about 10 days in the ICU. So the median protein delivered was about 1.7 versus 1.0 gram per kilogram per day, and the energy delivered was similar between the two groups. So overall, the incidence of a live discharge from the hospital at day 60 and 60-day mortality were not different between the groups, but higher protein delivery or the high protein group had significantly higher urea than the usual protein group, and high protein significantly worsened time to discharge alive from the hospital amongst a group of patients with baseline SOFA score of 9 or above, or patient diagnosed with AKI using the CADIGO criteria. The next is the PRECISE trial. So it is a double-blind RCT with 935 mechanically ventilated patients who are not contraindicated to enteral nutrition. So the patient were randomized to 2 versus 1.3 gram per kilogram per day of protein target provided by enteral nutrition alone. The protein dose was increased gradually by 25% per day to achieve 100% by day 4, and the intervention continued for up to 90 days in the ICU. So the intervention started around 1 day from ICU admission, and the duration of intervention was about 9 days in the ICU. So the actual energy and volume delivery between the two groups was similar, while the actual median protein delivery was about 1.87 versus 1.19 gram per kilogram per day. So the primary outcome is the EQ5D5L Health Utility Score 180 days after randomization, which is a quality of life score. So this score assigned death as zero score. So it is sort of a composite outcome of mortality and quality of life. So the study found that EQ5D5F worsened in the high protein group. And this effect remained the same after adjusted by Apache-2, sex, admission diagnosis, and nutrition risk score. And in the high protein group, there was also a trend towards increased mortality up to day 180 after adjustment of these variables as well. So the incidence of GI intolerance was also higher in the high protein group. And in subgroup analysis, higher protein significantly worsened EQ55F in female and medical patients. And mortality was also worsened in medical patients. So again, we see harmful effect with high protein delivery, and this harmful effect is even affecting the quality of life of the patient up to day 180. So the third trial is the target protein trial. So it is a clustered randomized crossover clinical trials. Nearly 3,400 patients aged 16 years or above and prescribed enteral nutrition were included during the study period. And they received isocaloric enteral nutrition formula with higher versus lower protein content. So higher was 100 gram per liter, lower was 63 gram of protein per liter for up to 90 days in the ICU. So the intervention started around 19 hours from ICU admission, and the average intervention was about 3.5 days in the ICU, which is relatively short. The median actual protein delivered was about 1.12 versus 0.69 gram per kilogram ideal body weight per day. So, and the energy delivery was similar between the two groups. So the primary outcome, days free of the index hospital and alive at day 90, was not different between the two groups. No differences between groups were found for several other clinical outcomes. But they found that ICU length of stay was significantly longer in the higher protein group. Discharge to home was about 4% lower in the higher protein group, and the urea level at day 10 was higher in the high protein group. And in subgroup analysis, heterogeneity of treatment effect, whereby the harmful effect of high protein was found for subgroup of patients who were receiving mechanically ventilation compared with those who were not receiving mechanical ventilation, and patients who received new renal replacement therapy at baseline versus no new renal replacement therapy. So remember, the protein delivered in this trial was just 1.12 versus 0.69 gram per kilogram per day. And this exposure to this high protein of 1.12 was short, about 3.5 days. Yet the potential harm was found even in patients who received new RRT at baseline. And lastly, this is a parallel group single center RCT that randomized 500 mechanically ventilated trauma and surgical patients with expected length of stay with expected ICU length of stay of more than 7 days to early enteral protein supplementation versus standard enteral nutrition. So the intervention started within 72 hours, and the intervention duration lasts for about 28 days. The actual protein delivered over the first 7 days of ICU stay were 1.2 versus 0.6 gram per kilogram per day. And the energy delivered was also higher in the intervention group due to the calories from the protein supplement. So about 86% of the enrolled patients were admitted due to trauma, and the other patients were surgical patients. And no difference between groups were found for the core primary outcome, the serum transthyretin and 28-day mortality, and most of the secondary outcomes. But the blood urea nitrogen was significantly higher among the intervention group in week 2, and there were significantly higher incidence of reintubation and diarrhea in the high protein group. Here we see again no beneficial effect of higher protein delivery even among trauma or surgical population that we traditionally believe to benefit from higher protein delivery. So here is the summary of the 4 protein trial, whereby an early that is started within 19 hours to 3 days of ICU admission, shorter that is about 3.5 days, or longer about 10 days exposure to higher protein dose. This high dose ranges from 1.12 to 1.87 gram per kilogram per day in heterogeneous group of ICU patients, including trauma and or surgical patient, was not beneficial, but harmful to subgroup of patients with more number of severely more number or severity of organ failure, particularly among patients with SOFA score of 9 or above, patients with acute kidney injury, including those who needed renal replacement therapy at baseline, those admitted due to medical reason, and those who were mechanically ventilated. So, what is the best approach to fit our patient, to fit our ICU patient after reviewing this large and high quality RCT? So together with Professor Christian Stoppy from Germany, Professor Emma Riley from Australia, and as well as myself, so we actually proposed this algorithm. And I believe that this is by far the safest approach based on the current evidence. So what we propose is that regardless of baseline nutrition risk or status, or whether you use indirect chemistry or predictive equation to determine the energy requirement, we need to increase the energy and protein slowly and progressively over the first week based on the suggested dose in this table. But if a patient deteriorates, regardless of the days a patient spent in the ICU, energy and protein dose should be reduced to low dose maintenance feeding. So this is a bit different from the current ICU nutrition guideline, whereby they just focus on the days a patient spent in the ICU, whereby they suggest giving high dose of nutrition after about 4 to 7 days of ICU stay. But the dynamic status of ICU patients are not mentioned. So for example, on day 10 of ICU stay, a stable patient will receive full feeding based on guideline recommendation. But do we still continue providing full feeding in patients with increasing number or dose of vasopressor, increasing level of organ support, or worsening level of organ function? So in this patient, right, we should reduce to low dose maintenance feeding based on this table. And this is based on our learning from the trials that we just reviewed. And one way that we can objectively quantify a patient organ function status is to calculate the SOFA score, sequential organ failure assessment score, daily. So if a SOFA score is in an increasing trend, or if the SOFA is 9 or above, then we need to be very careful with our nutrition dose. And besides daily monitoring of the clinical status of our patient, we also need to monitor carefully the phosphate, blood glucose, and triglyceride level to prevent overfeeding. And in patients with AKI, especially those not planning for RRT, and those with increasing urea, we need to reduce the protein dose. And we also need to be very careful with non-nutritional energy sources from medications such as propofol, dextrose, or citrate. And before reaching the full feeding, micronutrients also need to be provided at maintenance dose. So we believe that this is a safe approach that will provide maintenance dose of nutrition for body function while avoiding the harmful effect of early high dose energy and protein, as shown by the clinical trials that we reviewed just now. It is probably that some patients will benefit from higher nutrition dose early in the ICU stay, but we don't have a way to identify these early responders yet. And in all the trials, we cannot find any responders from any subgroup analysis. So, and our critical care nutrition group is trying to design some studies with the hope to identify subgroup of responders. And meanwhile, we can just be very careful to avoid the harm when providing nutrition to critically ill patients. And this is my last slide. So again, together with Professor Christian Stoppy from Germany and Professor Yassin Arabi from Saudi Arabia, so we just published this current opinion paper this year. So this is a summary table of the potential biomarkers or indicators for different clinical stages of critically ill patients with this suggested nutrition action, based on our learning from the trials that I presented to you just now. So we hope that this table and together with the flow chart in the previous slide can effectively guide clinicians on how to feed our patient safely while not compromising the nutritional status. So lastly, the take-home message is, based on the current evidence, we cannot be too aggressive in pushing nutrition to our critically ill patient, especially when the patient is very ill. But we also need to be careful not going to another extreme whereby we don't feed our patients at all. So we know that nutrition is a basic need of life. So our patient need nutrition to survive. It is just that we need to provide the nutrition intervention carefully and monitor it frequently. And with that, thank you very much for your attention.
Thank you, Dr. Lee, for the very comprehensive and informative presentations. Now we open the floor for the questions. So the participant may submit their question via the chat or Q&A function in the webinar. So while we are waiting for the audience, I would like to start a question if I may. So we always thought that more is always better, but it doesn't seem to be the case for the nutrition that we want to feed our critically ill ICU patients. So across so many trials that you have presented, higher energy delivery did not seem to improve the outcome. May I
Mm,
know what do you think why more calorie consistently has failed to translate into the benefit for all the clinical trials?
yeah. So yeah, thank you so much for the very good question. So I think there are actually many different group of investigators trying to explain why is that so. So I think one of the reason is that if you notice that all the trials that actually started the intervention very early and in the first year of critical illness, and we know that at this stage, uh, the patients are in a mostly are in a inflammatory state with anabolic resistance. So it is probably that the higher energy or protein delivery cannot be used effectively by the body. And this extra nutrient are actually uh, giving more burden to the organ of the body. And at the same time, we know that during the inflammatory state, the body actually produce endogenous energy supply by breaking down our muscle or fat tissue. So if we give full feeding together with the endogenous energy supply, it might be we might be overfeeding our patient as well. So for example, for the protein, there's a very nice mechanistic study by the Australian group. They actually compare the protein delivery between healthy population versus ICU patient. So they found that compared to healthy population, the ICU population had relatively normal digestion and absorption, but the incorporation of the protein into the muscle is 60% lower compared to the healthy population. So where can this extra protein goes to if we provide this additional more protein to them? So and we from the all the clinical trials we can see that all the high protein group had significantly higher urea. So probably this extra nutrition they are converted to waste products, and this increased the burden to the liver and the kidney. And you can see that the subgroup patient with AKI, they are actually harmed mostly by this extra protein. So and there's another group from the Belgium, the Leuven group that they actually studied autophagy. So autophagy is the our cellular housekeeping mechanism where they try to remove the damaged organelles. So they actually found that more nutrition will inhibit autophagy during critical illness. So I mean these are the different mechanisms that people try to explain why is the result that we see is there's no beneficial of early high dose nutrition, and there's a potential harmful effects. I hope that answers some of the question. Thanks.
Thank you. So I think we have one questions, very interesting questions here in the chat box. The questions is, do any of the study look at the gut tonometry and how does the gut function influence the outcome? And are there ethnic differences in between these findings? And are there any differences between the causes of ICU admission, such as polytrauma patient versus septic shock patients? And what are the effect of inotrope and vasopressin? Over to you, Dr. Lee.
Okay, there seems to be many questions in this one question. Okay, so I try to I try to answer based on what I remember. So I think I remember the last part. Okay, so the inotrope and vasopressor. So I think in my presentation I already presented that there are one study, Nutria 3 trial, that enrolled very high patients with very high dose of inotrope at baseline 0.5 microgram per minute, and they found that high dose of inotropes actually I mean high nutrition actually are harmful to this group of patient. So there are also studies, for example, the PREMIT trial, they try to exclude patients with very high dose of inotrope. So again, a high protein delivery is not beneficial, but there is an increased incidence of RRT. So secondly is ethnicity. I think that's what I remember. So I think there are several studies that look at they perform subgroup analysis based on geographical region, especially those multi-center international study. So they actually found no difference between groups. But there's I cannot remember whether there is a specific ethnicity subgroup analysis, but probably geographical region can be like a surrogate marker for this ethnicity. And what are the other factors that was mentioned?
Gut tonometry,
Sorry?
gut tonometry or gut function. Is there any role in influencing the outcome?
Yeah. Gut function, uh, I'm not sure. I think most of the study they didn't perform subgroup analysis based on gut function, but what we can see is that the studies actually enroll a large number of patients, a large number of heterogeneous patients, and the results are actually quite consistent across all the trials. So the results are actually replicated every trial, neutral finding and potential harmful effect. And I think there's one more factors that is mentioned. Because I cannot see the question. I don't know where is it. Function. Trauma. Okay. Whether it's trauma or, so I think there's a study that I presented just now, the last trial of protein is specifically among trauma or surgical population. So they also found that higher protein delivery, no different between the two groups, but there's a harmful effect for reintubation and diarrhea occurrence in the high protein group. Yeah.
Thank you so much for your explanations and also your presentations. I hope that we all have find these sessions beneficial and applicable to our own clinical practice. So with that, we will pass on the floor to Dr. Nick Aimi for the next sessions. Thank you so much, everyone, for the attention and the audience. Thanks.
Thank you, Ka Ting, and thank you, everyone.